Good morning, everyone. Welcome to Georgia Heart Grand Rounds. We thank Boston Scientific for supporting today's activity. The planners and presenter have disclosed no relevant financial relationships with any commercial interests. To claim CME credits today, answer the survey evaluation. If you are viewing via online, the link will be put into the chat. Those attending in person will receive the link at the end of this morning's activity. If you have a question for the presenter, please type it in the chat section and we will read it at the end. And now Dr. Samity will introduce to you our guest speaker.
Well, good morning, everyone. It's a privilege to be here this morning, and this is the second of our cardiovascular Grand Round series at the Georgia Heart Institute. And it's honestly my distinct pleasure to introduce sort of an icon of cardiology, certainly an icon of interventional cardiology, but also one of the most amazing people I know. And he's been a friend and a mentor for me over the years. And just with the interactions you've seen here, he's really an amazing person. So with that said, Dr. Spencer King is currently Professor Emeritus at Emory University. Spencer, I think, Spencer, you grew up in the Macon area. And so he's a son of Georgia. And he initially came to Emory University to train. And at the time, he was telling us at dinner last night that there was really no coronary angiography. Most of the catheterization work was sort of valve work that was being done. But Spencer was always at the cutting edge. He's been a pioneer in coronary angiography, which he really was one of the leaders to help develop, pioneer in interventional cardiology. And some of you may have seen the multi-purpose catheter that folks have been using. Well, Spencer was a co-developer of that. And over the years, he's trained more than 150 cardiology fellows. In 1972, he became the first director of cardiac catheterization laboratory at Emory University Hospital. I understand a few years before that, he used to come to Gainesville to do some moonlighting in the ER. So in late 1960s, as a fellow at Emory, he used to come up here and moonlight in the ER and stitch up patients at Hall County Hospital. But over the years, amongst his many, many accolades, is that he recruited Andreas Grunzig, who in 1980 came over, and with Spencer King and really his mentee, John Douglas, they opened up and revolutionized the field of medicine and really launched interventional cardiology. Spencer was the chairman of the EAST trial, which was the NHLBI trial that compared coronary bypass to multivessel angioplasty many years ago. He, in 1998, was president of the American College of Cardiology. And a year or two later, he became president of the Society of Cardiac Angiography and Interventions. For those of whom who've taken the boards in interventional cardiology, he was the chair of the interventional cardiology boards of ABIM for 10 years, from 97 to 2007. So if there are any complaints, you know who to go to. But the founding of that. And then he really was behind the concept of taking the Journal of the American College of Cardiology and creating a JACC cardiovascular intervention. And he became the founding editor-in-chief of that journal in 2008. As you know, that journal is now the highest impact cardiology, interventional cardiology journal of the world, the most circulated journal. And for a decade, he poured passion and expertise and leveraged all the people he knew around the world to really elevate our field to that level through that journal. Currently, Spencer is chairman of the New York State Cardiac Registry, which, as you know, has published some very, very profound and impactful work on all aspects of cardiology and some aspects of cardiac surgery. And he's participated in many, many committees at the American Heart Association, American College of Cardiology, and the NHLBI. Spencer has co-authored more than 600 papers. He's edited and co-edited more than 12 books, including Interventional Cardiology, Hearst to Heart. Most importantly, he's gone back to his roots, and he's gone to Mercer University, and for 2017 and 18 was chairman of the board of Mercer University. He's now a lifetime trustee of Mercer. And in addition to the really momentous impact he's had on our field, the whole concept of coronary brachytherapy that was initially a thought to try to treat restenosis. In the early days of restenosis, almost every drug that was tried, Spencer was involved or on the cutting edge of that. And amongst the many honors, he's Master of the American College of Cardiology. He got the Lifetime Achievement Award at TCT, and on and on. I want to say that I met Spencer in 2003 when we were interested in coming back to Atlanta, and we interviewed at Piedmont Hospital at the time he was there. And then, of course, I met him when I moved to Emory in 2005. But I can tell you that in my travels, you know, he is probably one of the one or two people in the world that I think has impacted our field and almost everyone he's touched. So it's with a great pleasure and distinct honor for me to ask Spencer to really launch these Grand Round series for us and to talk to us about coronary interventions, a half a century journey. Spencer.
I was enjoying that so much, I didn't want it to stop. I hope you filmed this. I hope you got all this down, and I'm going to use it in the future. Well, yeah, it is a great pleasure to be back here. I say back here because, yes, I did work for Hall County Hospital back in the day, and tried to sew up all the teenagers who were crashing their cars up in the mountains. And now I drive by here frequently because we have a place up at Lake Burton. So I think it's important that I have a chance to actually stop here and see what goes on. Also, Gainesville physicians were very important. And when I came back to Emory and started the cath lab at Emory, there was nobody else in town doing coronary arteriograms except Arnie Feodotin, who was doing it down at St. Joe's Infirmary, which was downtown Atlanta. And so Dick Stribling, Sam Poole, Henry Jennings, these guys at Gainesville were major referrers to me at Emory, and we got to help me get the cath lab going at that time. So it's good to be here. I think you've heard the best part of this already, so the rest of it may not be so interesting, but I hope you'll find it interesting. So we're talking about a half century. Half century, as I counted, goes back to 71. I came to Emory in 72, so this is not an autobiography, but there will be some personal aspects to it as well. And the only thing I didn't do, and as we prepared this, was to figure out how to change the slides. See, there we go. So what I'm going to talk about is not all of interventional cardiology, but coronary revascularization and how it started and how we got to where we are, and perhaps some speculation about where we may be going. Certainly it all started with Grunzig, but before Grunzig, there were people that were critical, and they came from different disciplines. Forssmann, you remember, there was the German who first put a catheter in his own heart, and back in 1929, and just showed that it could be done. We were doing a course in the Mediterranean one time. Willis Hurst and Bruce Logue and Ellis Jones and I were out there, and we were giving these lectures. And there was a fellow who attended the lectures from Kentucky. He was a German man from Berlin, originally from Berlin, and he had known Forssmann. And the quote I remember was, "Forssmann, yes, the stupidest man ever to win the Nobel Prize." That was his assessment. But Grunzig would never have gotten there without Mason Soanes figuring out how to do coronary arteriography, direct coronary arteriography, and without Rene Favalero figuring out what to do about it. I mean, there were other attempts at bypass surgery, but Rene Favalero certainly deserves a credit for putting bypass surgery on the map, in my view. And then there were people who said, can we do it a different way? Can we open up arteries? Charlie Dotter, a radiologist, was passing catheters into the leg, trying to open up the iliac arteries and femoral arteries. But by simply taking the diagnostic catheters of various sizes and shoving up through a lesion and opening them up, and then having telescoping catheters like that. And many, many others have contributed, of course, and some of those are here. The approach we use now is the Seldinger approach, regardless of whether we're doing it from the leg or arm or whatever. We do it by putting a needle in and then starting the procedure. Melvin Judkins created a lot of the catheters we use. Some people don't know this, but you know those curves on the Judkins catheters, and you see there's a radius to those curves. Judkins left and right, and particularly the left has a certain radius on the turn. And I asked his technician once, how did he come up with that? It's brilliant because they seem to fit and work well. He said, well, in the cath lab, there were these 3/4 pipes that came, and we would heat up catheters and bend them around those pipes, and that's why they're shaped that way. And we just did that to see what would happen. Werner Porsmann was in Berlin, and he had this idea that Grunzig later incorporated. The idea was, what if you could put a catheter in and then not to have to be like the Dotter technique. You didn't have to have huge catheters to open up a large hole in the artery. You could go in and then expand your catheters. So he had regular catheters with slits cut in them and a balloon inside to try to stretch the artery. I don't know if it was ever used, but he did come up with some gadget like that. But Eberhard Zeitler, who adopted the Dotter technique, although it was dropped in the US, hardly anybody did it because Dotter was perceived as being a bit out in left field. He had an article in Look magazine, which made him look like a crazy scientist. And he was a bit eccentric. And people said, we're not going to do that. But in Europe, people were doing it. And thank goodness that Eberhard Zeitler was doing it, because Zeitler eventually met Andreas Grunzig, or Grunzig met Zeitler. And here's Grunzig talking to Zeitler on the left and Charlie Dotter. And Grunzig crystallized this idea of how to develop a technique that could eventually be used in the coronary arteries. Started out in the peripheral arteries, and it was developed literally on his kitchen table in his own flat in Zurich. This is probably a recreation of some of the stuff that he used, but he made these catheters. They were plastic material. He learned how to mold them. He put them in his own oven. This kitchen table I've sat at many times, even in recent years. His wife still lives in the same flat. But he made these catheters, you say, a garage industry. Well, this was actually a kitchen table industry. And in the peripheral circulation, these things were applied, and starting as early as 1973 and 4, he was doing this kind of work. But in 1976, he came to the American Heart Association for the first time to show his experimental work in making it work in the coronary arteries. And this exhibit, this poster, was on one row, and on the back of it, I had a poster. And someone came to my poster and said, you got to see this thing. There's a guy over there that's putting a balloon in coronary arteries and trying to open them up. So I went, and this was dog experiments whereby he ligated the coronary artery with with a ligature, and then put a balloon in and blew it up and broke the ligature and showed the physiology of doing that. Saw the pressure gradient go down, opened the artery, and he has some histology on this poster and whatnot. This poster I've had all these years since Andreas died, and currently it's on exhibit at the American College of Cardiology in Washington, prominently displayed there. The idea was finally, a year later, taken to the patients. I told Andreas when I saw this poster in the time this picture was taken, I said, this thing's never going to work. But a year later, he showed up again at the American Heart Association to give another talk about the experimental work. But in the published poster, there's nothing about patients, but he showed four examples that he had done. And one of them was his first patient, Mr. Bachman. And he had this proximal LAD lesion, put the balloon in, blew it up. You see above the precursor of fractional flow reserve. You see the pressure was there, the pressure gradient. Before he crossed the lesion, no gradient, then he crosses and you see it and then blows the balloon up and the gradient is relieved. These balloons did not have guide wires. They did not have a central lumen for a guide wire, but they had a lumen for pressure from the tip of the catheter back. And so you could hook up to that lumen to get distal pressure, and then you got proximal pressure from your guide catheter. And that's the way these catheters worked. Well, once this was done, and that was a huge event at the meeting in the American Heart meeting that year, everybody wanted to go to Zurich to learn about this. And this is actually the third meeting in Zurich, and there we all are in there listening. They got bigger and bigger. Everybody would like to go and sit in with him, but the people in Zurich said, you can't do that. It's disruptive. So he began to have these live courses, and he had 4 of them there in Zurich. And at the third course, the one is pictured here, which was January 1980, he sat down beside me in a train and said, I think I'm going to leave Zurich. And I said, where are you going? He said, I'm either going to Germany or to the US. I said, if you go to the US, where are you going to go? He said, well, Cleveland Clinic is very interested, and that's the most famous place for bypass surgery. And I think that'll be perfect place for me. So I said, well, that's great. What do you really want to do with this? He said, I want to be able to guide this procedure. I think it'll get out of hand. I think people will ruin it. And I want to be involved in all the early development. And I want to be a professor. Now, some of you have been trained perhaps in Europe or been to places and understand that the European concept of professor is different from ours. The professor kind of controls everything, including the money in a lot of universities in Europe. And he wanted to be a professor. So at that point I said, well, you got a problem. You can't be a professor at Cleveland Clinic. And he said, why? I said, Cleveland Clinic does not have a medical school, which they did not. And it kind of stopped him. And he said, oh my goodness. He said, what do you think I ought to do? And he had had offers from Boston and Stanford and different places. I said, well, why don't you, give us a call. You're going to be in America next week at the Snowmass meeting. He said, why don't you give me a call? And he did. He called and he said, I found out I can get a flight back to Zurich through Atlanta, and I'm going to do that. So he came, and so I said, now what do I do? Because I hadn't told Willis Hurst anything about this. So Andreas was at my house, and I go over and I say, Dr. Hurst, this fellow Grunzig I want you to meet him. And he said, oh, no, wait a minute. He said, I've heard a lot about this guy. He's a prima donna. I don't want you to get involved with it. I said, well, as a matter of fact, he's at my house, and I'd appreciate if you would just meet him. So I took him over. He met Willis Hurst, and Willis Hurst was in love with him immediately. Andreas was very charismatic and very clear with his interest in the science of this whole business. So this began our recruitment effort, and we finally were successful. This is a picture of my wife and his daughter up at his little cabin overlooking the Lake of Zurich, and so this was that summer. After that, part of our recruitment effort, Gail stayed with him for a week, and he eventually did decide to come to Emory, and we started these courses. I'm impressed with this screen because one of his requirements was that we have a big auditorium. Some of you have been in the auditorium at Emory in the Woodruff building, and all these people want to come and see it. And he says, I want to have a screen for the video images from the cath lab, and also the live image of himself speaking or whoever was doing it. So we had these two rear project screens that I've talked to the guys here about, that were state of the art at that time, high resolution, quote, high resolution. But to do that, we couldn't transmit the signal by satellite or anything. So we had a fiber optic cable, which still exists, between the cath lab and this auditorium to take the direct video image and pipe it into the auditorium so that we could have high quality images for people to see. And those courses were some lectures, very little, because there's very little information to pass on from a lecture, but they were primarily cases that we did. Here we are. This is Dick Myler next to me, and Andreas, as we did those courses. Here's an idea of Andreas.
Andreas?
Yes.
Are you ready to go with your transmission?
Yeah, we're ready to go.
We're ready for you. Let's go ahead.
We already have done our angiogram, Dr. Holman. The stenosis is here. This is the stenosis. And the continuation of the stenosis is the diagonal. So we have the wire ready here, have the catheter here. It's cranial ungulated. The whole thing is taken this way and this way. So how's your chest, Lucia?
Well, you must have the balloon working now.
You must have the balloon working. Yeah. It worked, yes. What do you feel now? What kind of pain was that? Can you describe the location?
No pain, but how is it going?
Wait a minute. Behind the chest? There are two interests in conflict. You may see this. The interest. The patient wants to know how it's going, and I want to know how the pain was. So there are two interests, conflicts here. And the patient has always right, so we answer his question. I think it's going all right. We have crossed the stenosis, inflated the balloon.
It opened it up?
It opened it up, yes. But we are not finished yet.
No, that's...
And now you answer my question. This is the glass we are using to protect us from X-ray radiation, with side glasses as well. Then we have also something here, which I'll show you, is to protect our, can you see it? Protect our fluoride against radiation. The other things are routine, but a very, very intrinsic component of the whole procedure are those shoes. Without it, you will never make it. Can you show the shoes? Here, come down to the shoes. Without those shoes, I tell you something, you'll never make it. Okay.
Okay, Andreas, we'll see you over here. So he was quite a showman, as you see. And a lot of people came to these courses, and we did cases, and they watched, and sometimes things went well. The first course we put on, the last case was one. Now, Andreas said, well, let's send them away with something if these guys are going to start. So we had this type A lesion, LAD, very simple, straightforward. Of course, with the kind of equipment we had in those days, you had to be fairly straightforward. he said, "Well, tell." So he's doing the case. I'm making the presentation. I said, "Now, if you're going to start, this is the kind of case you should start with." So Andreas puts the catheter in, blows the balloon up. The vessel totally occludes. Patient goes into ventricular fibrillation. I cut this transmission, and anyway, patient survived. But I think we did a favor because all these people, probably half of them decided they didn't want any part of this. So we probably saved a lot of lives for people that didn't go into interventional cardiology. So this is all history. But since that balloon, I often think about what is the most important development. And actually, Patrick Suro has asked me this question once. We got to thinking about it. And of all these things, the most important development was the guide wire. Not just guide wire, but steerable guide wires. And that's what enables all the things that can be done today. And that's why we have this fight between surgery and angioplasty on some patients about who should have which one, because prior to that, it was a very small number of patients who actually could have angioplasty because you couldn't get to the lesions. But now you can. And I look at what's happened since those early days in 4 different decades. Once the balloon, of course, second 10 years had to do with new devices, all kind of things, cutters, scrapers, all atherectomy devices, lasers of all types. And the one that came out of it was stents, and then we go into the stent era. And finally, something to oppose restenosis, namely the drug-eluting stent era. And now some other new ideas are coming to the fore. In the 80s, angioplasty evolved a bit to have a potential to compete with surgery. As Aviva said, Andreas had proposed a trial before he died in '85. It was not approved by NIH, but in '86 we reapplied for it. We made changes. We put in a very high-level data and safety monitoring board, including Larry Cohn, who is the chairman from Yale, and Sabiston from Duke, and people like this. So we got some heavy hitters there to go to NIH and try to get this approved. And we did get the first R01 to study this question of angioplasty versus surgery, done with balloons only, no stents, no, just what we had starting in '87 when we began doing them. And then, but before Andreas died, he perceived that the balloon was not going to be the end of this story. So here's a little interview with him about what he thought about things.
For most of our problems at the present time, the balloon catheter is quite a good answer. But the more we depart, as I said, to more diffuse disease, the more we have to change our directions to additional catheter systems, catheters or instruments, which then could solve problems like getting rid of a dissection, which is like a flap hanging in the lumen, obstructing the blood flow. Catheters who are able to eliminate embolizations, plaques, thrombi, etc. So we have to have more armamentarium than the balloon catheter only. We need more than that.
So indeed, new things came along. There were so many things that everybody came up with. And we used to put on a course in Santa Barbara, a nice place to do it. But we invited everybody that had developed something. And they came, and we did this for about 8 years in Santa Barbara and published a few books related to that. There were lasers of all types. Everybody had some kind of laser gadget, and the kind that's available now was one of them, but there were things including a balloon laser. Richard Spears came up with that the laser was inside a balloon. And most of these things didn't work. One was called spark erosion. This is like a bovie, just to burn your way through. Now, cycle has gone through. Now in structural heart disease, this kind of technology is being applied, but not in the coronaries. Atherectomy, John Simpson's device was a big splash for a while, and then faded out. So many other, there are a lot of these kind of devices, but the one that survived was the stent. The stent was first brought before Andreas died in '85. This fellow, Cesar Gianturco, radiologist, brought this stent. He had developed this for peripheral circulation, and it was just a wire coil that was back and forth, and it looked something like the spring on a pin or something like that. You see a picture of it here with the scanning electron microscopy. So we studied this thing in the experimental lab in pigs and saw the healing of it and what it did with platelet adhesion and so forth, with Keith Robinson doing most of the work, and Gary Rubin was a fellow then with us, and he worked on it. So that was our first exposure to stents. But when we put these stents in, we created another problem. The stents, by the way, were not designed to cure restenosis. The stents were designed to solve the major problem we had, which during our first 2 years, we sent 6% of the patients for emergency surgery. And you can imagine how popular we were, particularly on Friday afternoon, both with surgery and anesthesiology. So these were to solve that issue. And indeed, we got approval for a single arm study of stenting. If a patient stenosed, if a patient had an acute closure at the time of the procedure, we would still go to surgery, but we'd put a stent in to open the artery and maintain it open till it got to the OR. And it stayed in, of course. So we did 10 cases like that, and that kind of got us going. But then it became clear that putting stents in really resulted in more neoendomal proliferation than if we didn't put a stent in. So in 1989 or 90, here's where we were in our thinking about restenosis.
Or perhaps by utilizing compounds that will tag to things that are in the vessel wall that will stay there over a period of time, and perhaps by placing stents or some other polymer material in the vessel wall that will elute drug over a long period of time. In conclusion, I would say that restenosis is a multifactorial problem that I think will be solved by, number one, improving the initial result of angioplasty, both by utilizing diagnostic and new therapeutic tools to end up with an artery that indeed is open and is not like some of these who've died that Bruce Waller has shown you. Secondly, there must be a biochemical approach to hold that artery open and reduce the proliferative response. It may be that the key to that is in thrombosis. It may be it's in a combination of reducing thrombosis and also treating a long, ongoing proliferative stimulus that may come from many sources, including inflammatory cells, including autocrine effects from dying smooth muscle cells themselves. And it may be that once potent therapies have been found, that we will discover that they're too potent for systemic use, which will spur on new development in interventional cardiology to find delivery systems for drug to be placed directly in the artery. Thank you very much.
So this was a symposium where I mentioned thrombosis. Valentin Fuster had given a talk right before me, and he said it was all thrombosis. We needed to find a way just to block the thrombosis, and restenosis would go away with it. So, but we were convinced that this was a wound healing kind of problem, and that we really needed to block the cell growth. And the idea of brachytherapy came from the fact that plastic surgeons, dermatology, and so forth, people had figured out that if you got keloid scars and you removed them, you could radiate the skin, you could block the redevelopment of the keloid, you could treat pterygium on the cornea with radiation. And so the concept was from that we started this. And this was effective for a while until, of course, drug-eluting stents came along and were a much more efficient and effective way to deal with the restenosis problem. Now, this is after the first drug-eluting stents were restudied, a 6-month restudy of patients done in Sao Paulo, Brazil. Here's Eduardo Sosa opening one champagne bottle, and Patrick Soros on the other side, and everybody celebrating the fact that the patients they restudied 15 patients at 6 months, and none of them had restenosis, and so there was this big celebration going on about this. Of course, interventional cardiology has developed many other techniques, and critical among those have been intravascular imaging diagnostic things such as ultrasound, which is now still underutilized, but I'm sure you all are doing a lot of this to optimize the selection of therapies for the artery, also to judge the outcome. Optical coherence tomography gives these incredible images of the vessels. The physiology, the fractional flow reserve, or the pressure gradient across lesions has been a very important development in interventional cardiology. Helps us understand whether lesions really need to be treated, and now clinical trials have indicated that at least for angioplasty, the treating the lesions with significant obstructive physiology is more helpful than just going in and treating things based on the angiography. So where are we now, 43 years or more later? Coronary interventions have progressed, no question about it. And despite the dominance of surgery in clinical trials in the past, it's still hard to figure out whether to do surgery or angioplasty in some patients. And I've watched this, and now that I'm not doing it anymore, I've become a bit more philosophical about how you are going to decide these things in a fast-moving, changing field. In the EAST trial, we saw that there was a comparable outcome initially, but as we followed, patients with diabetes, even in EAST, that was a small group of diabetic patients. The whole trial was 400 patients. But we saw that diabetic patients did not do as well with angioplasty, even balloon angioplasty, the kind we had and the kind of lesions we chose back then. And that's remained true through a lot of these studies up to the present time. But as I watch what you all do, I began to wonder where is this all going? Because lesions like this, left main disease, bifurcation lesions, now are treated routinely with interventional techniques. Is that the right answer or not? We've got trials now that suggest it may be okay for a lot of left main lesions like this. The use of support devices, as seen here, is still being evaluated as how helpful, how necessary that is. These are very expensive technologies that we continue to wonder about. Severely calcified, long severely calcified disease is now treatable. Formerly, this would never have been successful to treat these things, but now you've got atherectomy devices that you can do this with. Chronic total occlusions are the most common thing that move a patient from a PCI candidate to a surgical candidate. And I picked out an extreme of this, but here's a patient that for some reason surgery was not done. Patient had a total occlusion of the circumflex, the right, and the LAD. Here you see the circumflex artery opened up, and then the right coronary artery opened up somehow, and the LAD opened up. So the fact that these things can be done has made it now a really important question. There are new technologies still that we are just getting into. I just looked at a paper reviewing all the shockwave, the lithotripsy papers, trying to come up with an answer. Is this good? Is this better than atherectomy? Is this better than rotoblator for for these calcified lesions. And the conclusion is that it's really good, but the conclusion is totally flawed because nobody's compared these things directly head to head in randomized trials. But it may be, who knows? The idea, I've always had this idea that, in fact, I had a nice video I took out for the sake of time, but we tried everything in the early days of angioplasty. How do we open the artery better and get a clean opening and yet not dissect the artery and not cause trouble? And we tried all high pressure, long inflations, all kind of different techniques. And I always thought this is a calcified mess, and just pressing on the pavement will not open it up. And what opens it up is this guy with a jackhammer going with this pulsatile force. I said, we need a jackhammer in the coronary artery. Shockwave is kind of what that is now. The drugs we deliver, do we always need stents in there? We can block restenosis. We drug-eluting balloons. These things are all just coming around into use in a way that we can decide when and if they need to be used and whether they're going to improve things at all or not. So as we struggle with the idea of how to revascularize people, and at the present time, how do we get to that? So I was invited to participate in this review of the subject with Patrick Surois. And we looked at a lot of the things that I talked to you about this historic breakthroughs and perspective published in JACC a few months ago. And in there, we looked at some, for the sake of time, I'll just mention one of the things that I found very interesting. And that is there's a conflict in left main disease between trials. There's the XL trial showing that the endpoints are about the same between surgery and PCI. So left main, okay, that's fine. Then there's a Noble trial from Europe that says, no, surgery looked better. And you say, how is this? How do we get this disparity? Well, a lot of these trials, it relates to what the endpoints are and how they're adjudicated. And you can see here that in the bottom left, where it says SCI or XL definition, that's the definition that was used in the XL trial comparing surgery and PCI. And that definition, if you had a periprocedural MI based on enzyme elevations of a certain type, you went down as having an infarct. And if you use that definition on in this case, the Syntex patients, that very famous trial Syntex, if you just apply that definition, what you get is what you get on the bottom left. That is that surgery and PCI are the same. On the other hand, if you use the definition that's now more commonly used, the fourth universal definition of MI, where it's much harder to get a defined definition of a periprocedural MI, you have to have not only elevation in enzymes, but other supporting evidence. Then you see, looking at it that way, surgery is significantly better than PCI. So a lot of these trials you look at, we need to be very careful about how the endpoints are indeed adjudicated. If you look at meta-analyses of all the trials of drug-eluting stents, you say, well, how do we decide based on certain characteristics? And one of those characteristics is patients with diabetes. And you see that if we look at one of the most current and complete meta-analyses, the surgery still does better with diabetic patients. Same thing we found 30 plus years ago in the EAST trial, a very small number, but it still remains the case for diabetic patients. Patients without diabetes, you can't show that. The randomized trials show very comparable outcome at 5 years. And then you see a divergence depending on whether it's left main disease, which ironically seems to be a little better. Angioplasty seems to do better there, comparable to surgery in those, put those trials together. And triple vessel, particularly extensive disease, does better with surgery. These are great generalities, of course, but we still are learning. Now, to compare where we are today to those trials, though, is difficult because the fields are moving so rapidly, not only in the initial therapy, but in medical therapy patients are getting and so forth. So here you see if we took the Syntex trial, Syntex PCI at the top, you see a certain number of events. And then a trial called Syntex 2, which was a single arm trial, but using the same kind of patients done years later after Syntex. You see that the Syntex 2 PCI patients did about as well as the Syntex surgery patients did from the original trial. So you might say from that, gosh, we've caught up with surgery. Things are fine and everybody ought to have PCI. But surgery doesn't stand still either. At the bottom, you see the Syntex surgery patients, again, with their endpoints, compared to the XL left main patients. This is all left main disease. And you see that left main disease treated at the time of Syntex had one outcome, and now in the XL trial, a much improved outcome. So both technologies are improving. Oh, my East trial slide didn't work, but it showed what I just told you, that diabetes worked. So finally, we do have a trial of current stents, the second generation stents. Much of what I showed you in that other slide, including the Syntex trial, were with stents that were first generation, not as good as we have today. But now we have a trial of the current modern stent. We have a trial that also includes the use of fractional flow reserve, only treating the significant lesions that with PCI was found to be helpful. And that's called FAME3 that was just published in the New England Journal. And what we saw in FAME3 was that the composite endpoint, which in this case uses the definition of paraprocedural MI that's very much like that fourth universal definition, which does not punish surgery. So if you use that definition, and you also include repeat revascularization as an endpoint, you see that surgery does better than PCI at 1 year. This was a trial of non-inferiority. It did not meet non-inferiority. I'm speaking of it like superiority, but it clearly looks like it's better. And with surgery. And when we look at the kinds of patients that we're doing and go back to the things we worry about in our selection process, namely diabetes here, you see the diabetic patients seem to do better with surgery, and the patients without diabetes do about the same. And this has been true throughout the entire period, although there are other smaller studies that challenge that concept. And again, that's the average outcome. That's not what every patient's going to do. What else? How about the Syntex score is one of great interest. How severe is the disease? The Syntex trial divided patients into 3 terciles: the most severe, the intermediate, and the low risk. These are all patients here we're looking at with 3-vessel disease, but the ones at the low risk did not have a significant difference, whereas the ones with higher Syntex score did have a better outcome with surgery. That's in line with what we have gained from previous trials and meta-analyses. So even with this trial, which was set out to look at the new stent and the new methods of treatment and the new medical therapies that we're applying, more vigorous anti-atherosclerotic therapies, this is what we get. So this is the evidence. This is the evidence to deal with as we select patients for surgery or PCI, but it only informs a decision. And as I think about it, every patient is different, but also every institution is different. And I've talked about this for years, even before the evidence with angioplasty was as good as it is in Japan and China and whatnot. And I would show for certain patients advantages of surgery, and then I'd finish my talk and they'd present a patient which clearly should have surgery, and none of them did. They all had PCI because they weren't doing surgery hardly. So what happens at the local level to the patient depends on what the capabilities are and the results are in the local experience. And the evidence, which sounds like the gold standard thing of the randomized trials, are critical in informing us, but it cannot be applied independent of local experience. So let me conclude by talking about where we may be going, some of the things. What about what the real endpoint that I always talk about with Habib is what I want to know are not so much things about restenosis and reintervention and whatnot. What I want to know about is who has events, who has real serious cardiac events, who has heart attacks. And as we look at patients to select for revascularization in the first place, that's curing angina is one important one. And I think we're all on the same boat, the same page there. But also, how do we prevent events in the future? And the question is, many of those events occur in places that were not physiologically obstructive or even angiographically obstructive. And now we have some evidence that if we knew more about the plaque and we knew more about the physiology, we might understand which plaques are going to get us in trouble. So in this study, looking at the lipid content in the plaques and also the mass of the plaque, they were able to show some difference in outcomes, not hard outcomes. Most of this was just who had revascularization and so forth, but this is certainly an interesting area. Now, the real question is, are we going to be doing our imaging in the cath lab, or are we going to be looking at all these things non-invasively with CT angiography? And of course, we are looking at that. The cath lab folks here are not out of a job yet, but at some point, we're getting more and more toward looking with these methods. And of course, this is an area of extreme interest to the group here at the Georgia Heart Institute. What's Georgia Heart Institute? Excellent, I love that name. A lot of the work done in the lab, in Habib's lab at Emory, looked at this and looked at the impact of shear forces, how the blood flows over these plaques, how plaques form, also how plaques rupture. And this kind of flow dynamics has been a critical component. Also, characteristics of the plaque, some solid characteristics like the low attenuation plaque, the positive remodeling, the amount of plaque you have, the calcification, spotty calcification. All these things may be important. One of the most important ones is the thickness of the cap over the plaque. And that one I don't think we've solved yet. But there are technologies that may be able to take the patient, do non-invasive imaging, come up not only with whether you have obstructive disease, but what the prediction is, just like the Watson computer that tells you if the elevator is going to fail or the engine's going to fail. They can tell you if the coronary artery is going to fail somewhere in the future. So where does this leave our specialty? Where does this leave the interventional cardiologist? Habib mentioned that I chair this New York State Registry, and I looked at our data, and for elective patients in New York State, we've declined this much in elective cases over the past decade. So elective interventions have actually gone down, not because surgery went up, surgery went down as well. But it went down primarily because things like the ischemia trial, so things like more confidence in medical therapists modifying the progression of disease, maybe influenced things. Certainly emergency cath, unstable syndromes have not gone down, and STEMI, of course, it remains high. So what are the prospects for the future? I think for STEMI, it's probably stable. I think virtually every STEMI that happens ends up in the cath lab, with some exceptions, but nobody's doing thrombolytic therapy. We have cath labs everywhere. People can get to them. EMS has gotten better. I hear it's fantastic here. Acute coronary syndromes, I think that's also a stable situation because most are already being referred. They've also been renamed. We used to have a lot of stable ischemic heart disease, but because of the reimbursement for hospitals, you get a lot better reimbursement if you're unstable. So I find that very few people are stable anymore. The true stable elective things, as I pointed out, probably declined. Redo revascularization has gone up because of the technology. You can do these things. Surgeons don't want to reoperate lots of times, and there are techniques to deal with patients that had surgery years ago, who had angioplasty many times before. So the redo field, okay, that's a business for the future. And what about this asymptomatic patient? What about interdicting plaques? What about elective stenting or some other intervention to try to prevent events in the future? That's a whole speculation depending on multi-scan CT and physiology and perhaps other diagnostics that will tell us eventually when we have trials of that sort of thing, whether we can actually do anything about it. So there's an area that for those who are early in their career in interventional cardiology, you may not have to go totally to TAVI and other things to keep you in business. There may be coronary work related to that. But these advances may indeed make diagnostic coronary arteriograms obsolete somewhere in the future. And if non-invasive imaging, physiology, and biomarkers ever able to identify which patients are going to have events and which are not, the new question will be, what will PCI add to advanced medical interventions? We've come a long way from Andreas's poster presented in 1976 and shown here in the Hart House in Washington. And we've come a long way from Mr. Bachman, the first patient, and went angioplasty. Still, he's doing fine. He had his angioplasty done with the simplest, crudest technology you can imagine. But he's still kicking and looking probably better than Bernie Meyer, who was the person who identified that patient and took him to Andreas. Bernie was a resident in Zurich at the time, and certainly better than the old guy on the other side. So coronary interventions, I think, still have a bright but a very different future, and it'll be up to some of you to determine what that future will be. Thank you very much.
That was amazing. I obviously have a few thoughts, but I'd love to open it up for questions. And do we have a microphone, Suzanne? Stan Winston.
Dr. King, thank you so much for sharing your wisdom and experience with us. I mentioned this to you before. Please share with us how you look so good and so healthy at your age. You don't have to share your age, but I just want to make a comment. You just, I agree with Habib. You are an icon to cardiology and to the field of cardiovascular medicine, and it's an honor for you to be here sharing your wisdom with us.
I don't know how I look, but I am, however I look is due to my mother, not to me. Because everything I talked about, of course, pales in comparison to what happens to our bodies when we inherit bad luck or when we misuse them in various ways, which we all do. I don't know. I've never had to answer that question, so I don't, obviously don't have a very good answer, but thank you for the question.
I will say though that I saw that there's one of the photos that you showed in terms of recruiting Grunzig is where you really deployed your secret weapon. You spent a week in Zurich.
No, my wife spent the week in Zurich.
That's what, that was your secret weapon. That's part of the reason. No, I mean, Gail and
No,
Spencer.
let me dwell on that a little bit. So I didn't mention this part, but after he did those first cases, we had this outfit called the South Atlantic Cardiovascular Society. Some of you may have heard of this. It still exists apparently. And we put on meetings, and I was in charge of this meeting in Kiowa Island, South Carolina in 1978. And somebody said to me, we got to have a speaker. We should have somebody come and give this talk. And what about that guy that did the angioplasty? Does anybody know him? I said, well, I met him when he showed this poster. I'll ring him up. So I did. And he said, well, it's in August. August, Europe is closed in August, so maybe I'll be able to come, but I don't know. I can't tell you right now. So time went by and I didn't hear anything. And the people who were the local organizers in South Carolina kept bugging me, said, you got to get we don't have this outside speaker, because the rest of the talks were just members of this small group. We had about 80 people that came to this meeting from Florida to Virginia. And I said, okay, well, I'll do something. So I knew Peter Block had some rabbit experiments with balloons. So I rang him up and I said, Peter, would you like to come down to this boondoggle thing in South Carolina and do this talk? He said, yeah, I'll come and bring Betsy, and that'd be fun. Hung the phone up. 5 minutes later, the phone rang and it was Andrea. Said, okay, I can come. I'm bringing my wife and my child and we're flying first class. And we had budget of about that big to handle this thing, but we sucked it up and he came. And when he was there, I picked him up at the airport in Charleston. He was absolutely irate because the issue of Hurst the Heart had come out, and there was a chapter that he had just seen on balloon angioplasty written by his boss and nemesis in Zurich, who really was putting his thumb on Andreas and not letting him do anything. Andreas had no knowledge of this chapter. His chief, Hans-Peter Kreinbuhl, had never done an angioplasty, but had trained at Grady in the past. And Willis knew him and contacted, said, well, you're at the place. So the guy wrote the chapter. Andreas was, I said, well, this is the end of him. I'll never, but he came and had a great time, and he met Ellis Jones and Joe Craver and some other colleagues. And so he says, I think he developed a sense of, not being against him. In Zurich, people were against him. And the surgeons were a great help in recruiting Andreas, I think, because of that. And then once in 80, they joined in the throng of people who wanted to welcome him.
Yeah, I did. I wanted you to comment a little more about that, because in my years at Emory, both you and John always talked about the collaboration with cardiac surgery that really made all this possible. You mentioned 6% rates of emergency coronary bypass in the early days, but then Joe Craver and Dr. Ellis were both cardiac surgeons. Talk a little more about that relationship. And how, John Douglas always says that there appeared to be a trapdoor in the cath lab where when the vessel could not be maintained open, they would just push this button and within minutes they were in the operating room.
Yeah, several minutes. I mean, but yeah, no, there was, we're all friends. I came to Emory to start the cath lab. There's no cath lab in Emory Hospital. So I came as the catheterizer. People said, I came actually with a dual appointment in radiology and medicine. And people said, are you a radiologic cardiologist or cardiologic radiologist or whatever? I said, no, I'm a surgical pimp. And so I had some creds, street creds there for with the surgeons. You know, I mean, the Stribling, Jennings, Poole, all these people sending, you know, we got along quite well. So there was a challenge with some things, but the main challenge we had was with cardiac anesthesiology. They did not want to be surprised with a failure that they didn't know about. So there were some face-offs and things like that. But and Bob Guyton I didn't mention, but of course Bob was our key guy in the East trial. He headed up the surgical piece of it. So that was that was a lot of fun and games in those days.
I should mention that Robert Guyton followed in the footsteps of Spencer and John Douglas and got the Lifetime Achievement Award at the Georgia ACC this year, a couple of weeks ago, which was wonderful to see. Any other questions from the audience? Suzanne, I can see a couple of people wanting, well, maybe if you can bring the mic down in case Dr. Hastings has any comments to make. So Spencer, just talk about the future. You talked a little bit about where interventional cardiology is going and how, you know, ACS is probably here to stay. How far away do you think we are from some of these non-invasive tools and potentially some biomarkers identifying high-risk patients, high-risk plaques? And I know you've been thinking about ways to stabilize these high-risk plaques. Do you think it's still sort of a far-fetched dream, or can you, that wonderful prediction you made on restenosis in 1990, now give us your prediction on this new chapter? How many years away are we at identifying those plaques and potentially locally treating them, if at all?
Well, I'd like to think, you know, we're not so far away, but my hope is that it'll be unnecessary. My hope is that you know, Brown and Goldstein has told us a long time ago that coronary atherosclerosis was cured because we were going to just treat the LDL cholesterol, and that was all we needed to do. And that's been a big story, but it's not the end of the story. But now we have so many things, obviously, that are targeting atherosclerosis. And so we will continue to modify what we decide to do invasively by what we need to do. And that's where I think we need a lot more studies, a lot more information. Is the patient that can be stabilized. If you think about it right now, the psychology, I think, among patients and physicians is still, I got a blockage, I got to get rid of it. Why? Well, I've heard people have heart attacks and they die from that. I don't want that to happen. And my uncle did, or my aunt, or my parents did. If the psychology ever moves to the point of, I'll use COVID as an analogy. We're all terrified. We got a mask on, off. We don't know what to do. We can't go anywhere. Why? We saw people were dying of this thing. If it ever evolves to the point that it's a bad cold or something, we won't focus on that area. Take it back to coronary interventions. If our preventive or secondary preventive therapies start stabilizing plaque to the point that, yeah, you got atherosclerosis, your coronary arteries don't look like they did when you were a kid, but neither does your forehead. You know, you look different on the inside, you look different on it, but the inside difference is not going to kill you. Now, if that psychology comes through, we're all, you know, we're not out of a job, we're into a different job. We're into the job of applying those kind of therapies. So where is all coronary revascularization going? It's going to depend on what we can accomplish with medical therapies. But during that time, advances will occur. Advances of some of these things will occur only if they're profitable, because we live in America. And actually, if we lived in China, it'd be the same thing. You wouldn't probably, or wherever. But we've got to show that not only is it possible to interdict plaque and whatnot, and you can show that can be done, and even, but then you got to compare that to your most vigorous therapy without intervening on plaque. Then you got to have studies that prove that. Then you've got to pay, multiple billions of dollars to get that done. So I think where we're going is hard to, like Yogi Berra said, it's hard to make predictions, especially about the future. But I've learned later that he wasn't the first. I think Nostradamus or somebody probably said that as well. So I don't know, but I think it's fun to think about, because the plaque is we know so much about it that if we can non-invasively identify it. Think about what we do today. Patient in Clayton, Georgia gets a stress test, and it's positive or something. He says, well, I've had a little chest. I'll tell you what, we're going to send you down to Gainesville to have a heart cath. And this old mountaineer up there says, hey, yeah, what does that do? He said, well, they put a thing in your leg, just saying, nothing to it, take these pictures. But by the way, we don't know what they'll find. So take your family with you, because, they may have to put stents in you, and they may have to open you up and operate on you. And the guy says, give me a break, doc. I just give me some pills, do something. I don't want to go there. I've seen that syndrome. My wife is from South Georgia, so I've seen her relatives who are reluctant to go to Atlanta. Going to Gainesville may not be as threatening. But think about it. If you had non-invasive imaging, if it was like a mammogram, and we're going to send you off and get an X-ray and see, and then we'll tell you what we think, and we'll get if you could go and have a non-invasive CT that would tell you not only the coronary anatomy, but how obstructive your lesions are, and even potentially how threatening some of them are, and whether, despite the fact that your symptoms are now controlled, it still may be important to consider an intervention. Or you clearly don't need an intervention, but all those things are decided without you getting on the table and not knowing if you're going to get stents or surgery. And my hope is that we'll get to that point, because I think doing that will enable us to get to patients earlier and probably save some lives.
Well, we talk about patient-centric care. You just talked about it, right? And Spencer's always puts the patient in the center. And in this case, that person would stay in Clayton, get the care they need. Well, there are many more questions I'm sure we all have, but I just want to thank you so much for coming and enlightening us and stimulating us to think and keep working. So thank you very much for coming.
Well, I want to thank you, because and tell you guys that Gainesville is not your grandfather's Gainesville, and this is not Hall County Hospital, and it's not even, well, I won't make any other analogies, but you're on the cutting edge of all these things we're talking about with what you're doing on the investigation side and on the device development side. So congratulate the Georgia Heart Institute and Habib. Thank you so much.